Okay, everyone, I think we're going to get started with the next session. How's everyone doing? Everyone feel confident with if they get a question about pediatrics on the exam now? Okay, good. All right, so we're going to move to our next presenter, who is Dr. Jennifer Dugan, and she's going to cover the section on geriatric pharmacotherapy for us. Dr. Dugan is a clinical pharmacy specialist at Kaiser Permanente in Aurora, Colorado, and a clinical assistant professor with the University of Colorado School of Pharmacy. Dr. Dugan obtained her PharmD degree at the University of Texas in Austin and completed a 2-year pharmacotherapy and primary care residency at the University of Texas Health Sciences Center in San Antonio in South Texas Veterans Healthcare System. Dr. Dugan was co-investigator on several heart failure clinical trials at the VA and University Hospital in San Antonio, and then accepted a position as a clinical assistant professor at the University of Missouri, Kansas City, where she practiced at a community hospital supporting the inpatient family practice service and pulmonary service. Dr. Dugan then moved to Denver in 2003 to work at Kaiser Permanente, where she practiced in geriatrics for 7 years and supervised clinical staff in palliative care, continuing care, infectious disease, inpatient services, and gastroenterology. And she has recently moved into a new position in primary care clinical pharmacy services, but she continues with a passion for improving drug therapy in the elderly population. So please help me in welcoming Dr. Dugan for the geriatrics portion of the course.
Thank you. I'm delighted to be here and to talk about geriatrics, which I think is a super important topic, especially because our patients just keep getting older, and because this is a topic that's sort of a challenge for the pharmacotherapy exam because I feel like there's a lot of gray areas. So we'll try and focus as much as we can on guidelines and have a chance to talk about some of the risks and benefits of different medications and cover a lot of different disease states today. So the first thing is I have nothing to disclose, which I love talking about myself in the third person like that. So first we're going to start with patient case 1. So NH is an 85-year-old woman in a nursing facility. She has type 2 diabetes, hypertension, moderate dementia due to a cerebrovascular accident, and is status post hip fracture. She's currently on glyburide 10 milligrams daily, lisinopril, metformin, donepezil, aspirin, a multivitamin, zolpidem PRN, meclizine PRN, and a bowel regimen. So the first question is, which functional assessment is most important to evaluate? Is it IADLs, depression, gait imbalance, or pressure sores? So as we look at these options, IADLs are things like being able to manage money, cook, balance a checkbook, and all of these things are not going to be an issue now that she's already in a nursing facility. The second thing to look at is depression, which could be an option here, but we're going to talk about maybe some more pressing issues. And pressure sores would be one that maybe we would think about if she had more severe dementia. But again, this is someone with moderate dementia who is on 2 high-risk medications. So she's on both zolpidem and meclizine. So this is somebody where the correct answer would be C, gait imbalance. So continuing with the same patient, we have some labs for this 85-year-old woman, including a fasting glucose of 90, a sodium of 138, a potassium of 4.5, chloride of 102, bicarb of 25, BUN of 30, serum creatinine of 1.8, and a TSH of 4. So everybody grab your cards, please, and answer the following question. Which pharmacokinetic parameter is most likely to be changed in NH? Is it A, blue oral absorption, B, red distribution, C, green metabolism, or D, yellow renal excretion? So please hold that. Good. So hopefully this is a pretty easy one for everyone. That the answer is D, renal excretion. So obviously, this is something that we do worry about is physiologic changes in the elderly, and there's just a couple of pearls I want to talk about to sort of summarize some of the things that you'll find in your chapter. In terms of absorption, yes, there's sometimes a change in the absorption, but most of the time, elderly patients absorb to mostly the same extent for oral absorption. For transdermal patches, we can sometimes see a reduction in absorption if the patient has insufficient subcutaneous fat. So for a lot of patches, this may not be of concern, but for something like a fentanyl patch, this would be something where the efficacy could definitely be could be altered in an elderly patient who did not have a lot of subcutaneous fat. Now, just of note, as patients get elderly, they do lose muscle mass and do gain fat, but obviously we've all seen little, 90-year-old women who do not have a lot of fat on them, and those would be patients where that would be an important consideration. Distribution may be increased for highly protein-bound meds. So for patients where their albumin starts dropping, then obviously highly protein-bound medications like phenytoin or diazepam or furosemide or indomethacin, all of these medications potentially would not be as well bound to the albumin and could have higher free levels. So that's just something to think about in elderly patients. Metabolism can impact benzodiazepine choices. We'll talk a little bit more about benzodiazepines and how they're not ideal medications in the elderly, even though we see them on them all the time. But there is metabolism can be an issue here, and so we're going to want to choose medications that are not as affected by the reduction in metabolism in the elderly. So if we are picking a benzo, we tend to stick with the LOT drugs. That's LOT, which is lorazepam, oxazepam, and temazepam. So those three, if we have to pick one in the elderly, tend to be ones that we choose because of the metabolism issues. And finally, just a reminder that renal elimination is not just about serum creatinine. So obviously this case is pretty easy. The patient has a serum creatinine of 1.8. That's pretty obvious to us. But I just want to tell you about my mother-in-law. So she is a 83-year-old woman. She has lost some weight, so she weighs probably around 110 pounds. And let's say her serum creatinine is 1.1, right? So totally normal serum creatinine on most people's lab tests is going to come back at 1.1. So most people are going to see 1.1 and be like, okay, no problem, she's got normal renal function. Well, hopefully not you guys, but other people. And so in her case, as an 83-year-old woman, her estimated creatinine clearance is 31 mils per minute. So just think about that. She's got a normal-looking serum creatinine, but her creatinine clearance, just because of age and weight, is already about 30 mils per minute, where a lot of dose adjustments need to be made. So just keep that in mind. All right, patient case 3, please grab your cards again. So, based on your assessment of age and disease-related changes in this 85-year-old woman, which is best to address first? Are we going to talk about diabetes management, Alzheimer's disease treatment, hypertension treatment, and stroke prevention? And just as a reminder, here are her medications, because you've already taken care of her zolpidem and meclizine problems and gotten rid of those, but here's what she's left with, and which one is the most important one you want to address. So again, is it A, diabetes, B, Alzheimer's, C, hypertension, or D, stroke prevention? So please hold up your cards. Good, so I see lots of blue. And that's correct. So here's a patient who's on glyburide, which is not going to be our preferred sulfonylurea in the elderly due to the long elimination of that medication. And we may need to weigh the risks and benefits of metformin as well. All right, case number 4. To maintain and improve function in NH, which intervention is best to implement? Are we going to add a calcium and vitamin D supplement, add simvastatin, add warfarin, or assess for incontinence and treat with anticholinergic agents? So please grab your cards, and remember, this is an 85-year-old woman, moderate dementia, CVA, status post hip fracture, and what treatment are you looking at? Good, so we have mostly A. Now, as you all have heard in the news, the U.S. Preventative Task Force recently came out saying that there was insufficient evidence to recommend calcium and vitamin D for primary prevention, but this is a patient who's already had a hip fracture, and this is also a patient who's in a nursing facility. And there is a good deal of evidence that vitamin D can help to prevent falls in this patient population. She's likely to be vitamin D deficient, just living in a nursing facility because they don't get to go outside as much generally. We could talk about simvastatin. Here's a patient who's had a CVA, but again, she's 85 years old, so the risk-benefit of adding it at this point is probably needed to be considered and probably not be the best intervention for her. Adding warfarin, we don't have any indication that she's has AFib or is in need of any additional therapy besides her aspirin daily. And assessing for incontinence and treating with anticholinergic agents. We will talk more about incontinence, and it is important to kind of think about this for patients. But again, this is a patient with moderate dementia on donepezil, so the chances of us adding an anticholinergic agent would definitely have to be more significantly considered before we just treat it. So I want to review a few more common drug-related problems in the elderly, because this is a patient population where we really do see lots of drug-related problems, as all of you I'm sure are aware of. One of the things we can see is overuse of medication. So this can be everything from, no one ever stops their omeprazole that they got started on once and it just continues forever. This could be adding medications to other medications to treat side effects, etc. We also see underuse in the elderly. For example, you may have a patient who's got systolic heart failure, and someone looks at them and goes, well, they're 79, so, we don't necessarily have to do that, or they're worried about fall risk or something else where you think, hey, let's at least give this patient, the drugs that do have mortality benefit. Anticoagulation and AFib, sort of the same thing. People often say, well, I don't want to use anticoagulation because they might fall down and get a hematoma. I'm like, well, what's worse than a hematoma? Having a giant stroke. This is the highest risk patient. The age adds a lot of additional risk for AFib. So making sure that you're helping a physician and family to weigh risk benefits is important. Drug therapy post-MI and untreated depression, again, other examples where we may see underuse in the elderly where pharmacists can really be involved to make sure we have them on appropriate medication regimens. Medication adherence is a huge thing. Obviously, we're seeing more about this in the literature. There can obviously be unintentional non-adherence where the patient doesn't even know that they're supposed to be taking a medicine, and that's obviously a role for pharmacists. A lot of times patients get started on titration packs, so maybe they're started on a metformin and it says, do not refill, contact provider for dose adjustment or whatever, and they think that means do not refill, like you only had to take this for, 30 days, 60 days, and now your diabetes is somehow not needing medication. So again, just making sure for non-intentional adherence we address those issues. But there's also intentional non-adherence, which could be related to perceived over-medication. Some patients really are like, well, this is too many meds, so I'm just going to pick the ones I think are the most important. Obviously, adverse drug reactions are very important, and patients often will stop taking a medicine and say, well, I don't think it was important enough to tell my doctor about, but I didn't think it was worth taking. And obviously, cost becomes a big player in a lot of patients' lives when they are trying to decide which medications to take. Use of inappropriate medications we'll talk a little bit more about in a few minutes. And then, of course, adverse drug reactions. Elderly are more susceptible to that, so that is a common drug-related problem we do see in the elderly. All right, so get out your cards again, please, and we're going to talk about another 85-year-old. This is a woman seen in a primary care clinic for dementia. She has an MMSE of 24 out of 30. Her past medical history is significant for Parkinson's disease, hypothyroidism, and osteoarthritis, and she is independent in her ADLs. So she's currently on carbidopa-levodopa, the controlled-release product, trihexafenadil, celecoxib, levothyroxine, docusate, and bisacodyl. So which medication is the best to consider first? Do we want to add donepezil 5 milligrams a day, do a slow dosage reduction of carbidopa-levodopa, do a slow dosage reduction and discontinuation of trihexafenadil, or replace celecoxib with acetaminophen? So please hold up your cards. Great, so I see some C's, which is fabulous. And we're going to talk a little bit more about anticholinergics and other potentially inappropriate medications in the elderly. This is something where more and more attention is being brought to. Obviously, you're seeing more information in the news about things like, sedative hypnotics having mortality risk in the elderly. If you've ever worked in a hospital, obviously you've seen a lot of delirium patients come in related to even OTC medication use. And obviously things like Medicare 5-star, HEDIS measures, whatever setting you work in, there's obviously a lot of focus on this. So the big offenders on various lists, whether it be the Beers criteria or other places, generally include diphenhydramine, because in the elderly it is one of the worst offenders in terms of anticholinergic action and possible side effects. That doesn't mean if a patient's having an acute allergic reaction you're not going to give it, but it does mean that even for people who float at pharmacies or are seeing diphenhydramine, go out to an 85-year-old, really be asking the question of why are they taking it. And a lot of people don't consider this a medication. This even happened with my father-in-law the other day, where he had fallen, and I was talking to him about it, and he was already on Lunesta, which is a whole other story we'll talk about in a second. But then I said, well, what happens when you don't, when the Lunesta doesn't help you sleep? And there was a pause, and I said, do you take Benadryl? And he said, yeah. And I was like, did we not talk about this like 6 months ago about the OTC use? So again, he didn't even think about, he gave me his whole medication list, but would he mention Benadryl? No, because it wasn't one of his medications. So again, just keep that in mind. Long-acting benzodiazepines like diazepam and chlorodiazepoxide are two of the big ones that end up on the medications to avoid list. Skeletal muscle relaxants, tertiary TCAs, amitriptyline, doxepin, and imipramine are three big ones. We still do use some nortriptyline and disipramine because they're a little less anticholinergic, so they tend not to be on as many of the lists. GI antispasmodics like dicyclamine, indomethacin tends to be the most GI toxic, piroxicam, promethazine is fairly anticholinergic, the butalbital compounds, Z-drugs, all of these are listed in your handout. The Z-drugs are new, the zolpidem, zaloplan, and ecopiclone, or the Ambien, Lunesta, and Sonata, and obviously there are lots and lots of patients on this because we thought it was safer in the elderly, and then we found out that it increases falls and fractures and other things, so that's one of the new banes of our existence in geriatrics. So one of the reasons we worry about anticholinergics so much is because a lot of anticholinergics are able to cross the blood-brain barrier. So I want to orient you to this slide. So these are patients who are on a cholinesterase inhibitor, so they're on donepezil or galantamine or rivastigmine, and this is their decline in MMSE over time. So the average decline in MMSE over time is about 4 points per year. So and if you have a patient who benefits from donepezil, then maybe it slows their decline some, and we'll talk more about that in a minute. So look at the difference in the graph. So the patient who was on donepezil, but in combination with one or more anticholinergics, so maybe they're on trihexyphenidyl or oxybutynin or dicyclamine or something else, they have the same rate of decline as people not on donepezil. So basically they lose every bit of their benefit by having the anticholinergic completely block its benefit, whereas the ones who weren't on the anticholinergic did show a difference. So again, this obviously has the potential for significant impact for the patient. The other thing that we really want to watch in geriatric patients is the prescribing cascade, so treating an adverse effect with a new medication. So this happens, and I know you've all seen it, but I just get so frustrated when I see this. So a patient on metoclopramide maybe develops some EPS or some Parkinsonian symptoms, so they get tried on levodopa. So now they're on two medicines. Donepezil obviously is a cholinesterase inhibitor, meaning it increases the acetylcholine in the body, not just in the brain, but also in the urinary system. So we definitely see incontinence with it. And then they have oxybutynin added. Oxybutynin crosses the blood-brain barrier, completely negates the benefit of donepezil. Not a great combo. Diphenhydramine can definitely cause urinary retention, especially in BPH patients, and so then we see terazosin added. Amlodipine, for example, may cause some edema, and then we see furosemide added. So again, just being cognizant of these combinations, both in real life and on the exam. All right, we're going to jump to patient case 6. So this is an 87-year-old man with Alzheimer's disease who's on rivastigmine 6 milligrams twice a day. His family notes some improvement in his functional ability, but reports he's experiencing nausea and vomiting that seems related to rivastigmine. So what's the best recommendation at this time? Are we going to advise the patient to take his drug with an antacid, add prochlorperazine by rectal suppository, discontinue the rivastigmine and use memantine, or change the rivastigmine to the daily patch? So let's talk a little bit about dementia. So this is obviously becoming more and more of an issue for not just our patients, but our family members, and obviously many of us are affected by this. It's characterized generally by 3 different areas, by a functional disability, cognitive impairments, and then we often see behavioral and psychological symptoms as well. There are several different types of dementia. There are some reversible dementias from things like B12 deficiency or severe hypothyroidism. There's also frontotemporal, a mixed dementia, which tends to be like that they have a vascular dementia and maybe Alzheimer's as well, because all of it isn't explained by the vascular dementia. But the big 3 are the Lewy body, vascular dementia, and the Alzheimer's disease. So when we talk about some of the key symptoms that we see with these different types, so dementia with Lewy bodies tends to be characterized by visual hallucinations and Parkinsonian symptoms and a fluctuating alertness. So it looks kind of like a dementia and Parkinson's combo, but the dementia with Lewy body patients tend to definitely have more visual hallucinations than any of the other dementias. They often tend to be children or little people is often one of the things that you see. So there's a couple things about this. One, it's fairly common, but two, sometimes it's very disturbing to patients because they think that there's children around and they're supposed to take care of them, and it makes them very apprehensive. And sometimes they're very friendly, and in which case maybe they don't need necessarily directed treatment towards those visual hallucinations. Vascular dementia, again, this is caused by small CVAs or TIAs where there's an acute onset to it, usually from the first event, and then they have a stepwise deterioration as they have smaller events, and they tend to have focal neurologic signs. And Alzheimer's disease is basically a diagnosis of exclusion when we don't have any known reason for the dementia, and it has a slow onset and progressive decline, and as you saw in the chart, it's the most common type of dementia. Whenever we're talking about dementia, we also need to make sure we differentiate it from delirium, because I think a lot of times people use the terms not necessarily interchangeably, but aren't sure what to call it, and family members may be calling it one thing or another. So delirium is basically a more acute issue where there is a change in cognition for the patient, where they have either a memory deficit, they're generally disoriented, so they're not necessarily sure where they are. They definitely have difficulty with attention, and it develops over a short period of time, generally hours to days. So this is not like the slow onset, deterioration of dementia. This tends to be something that happens more acutely. It can definitely be medication caused, so you will see, patients can have delirium from the amitriptyline, diphenhydramine, the other meds we talked about. They can get it from topiramate. They can certainly get it from a urinary tract infection. All those things tend to be addressed and ruled out, and it's basically generally a cause caused by either a medical condition, an intoxicating substance, medication use, or more than one cause. So again, delirium is that acute onset thing that is definitely going to be different from the dementia that we're mostly going to focus on today. So we talk about therapy for dementia. We have a limited number of choices, and to be honest, they don't really work very well. So the cholinesterase inhibitor choices are donepezil, galantamine, and rivastigmine, and then we also have memantine. So when I talk about efficacy and safety pearls, it's basically this. The efficacy is not great. There are patients who benefit from it for sure, but when you look at the trials, they basically suggest a statistically significant benefit, and the clinical significance of the benefit on an average across the whole patient population is definitely questionable. Memantine is not any better in terms of its clinical significant benefit. So that's kind of where we're at. Everyone in this room, I'm sure, wishes that we had better drug therapy for this, or we had a vaccine, or we had something to do to try and minimize the effects of this, but we don't. In terms of safety pearls, there are GI issues with the cholinesterase inhibitors. We'll talk about that more in a slide. We do think about bradycardia and incontinence as two other things that we kind of worry about when starting a cholinesterase inhibitor. So when we're choosing between cholinesterase inhibitors, you can see some of the percentages here in terms of nausea, vomiting, and diarrhea. The rivastigmine oral is definitely the worst, so we see very little clinical use of that, and it's mostly, if it's going to be used, it's replaced with a patch. Donepezil and galantamine are both generics and tend to be more affordable for most patients than the patch. But in our patient case, the answer would be change rivastigmine to the patch because he's benefited from it, but obviously the GI issues are probably caused by the oral version of that medication. All right, patient case number 7. So RA is a 75-year-old woman, so she's not even in her 80s. She's a spring chicken. So she has Alzheimer's disease on donepezil 10 milligrams a day for the last 3 years. So her MMSE over the last 3 years has gone from a 21 to a 17. So she's at home with her husband. She can't do her IADLs, but she can do ADLs like getting dressed and taking a bath with queuing. So what is the next best course of action? Do we want to change her treatment from donepezil to rivastigmine? Do we want to stop the donepezil, add memantine, or add vitamin E? So this is a patient where we're going to be evaluating the efficacy to see how she's done over the last 3 years. In general, we don't want to wait that long before we evaluate the efficacy of starting a cholinesterase inhibitor. One of the things I say about cholinesterase inhibitors is that it is not, great for everyone, but I think most patients should be given a trial on it if they're mild to moderate, but then they should be assessed, and if it's not working, then stop it. So I think we don't start it enough, and I think we don't stop it enough. So I think these are medications that we can use, and in the right patients, we leave them on, and in the patients who aren't going to benefit, we take them off. So ideally, we're going to evaluate the patient in 3 to 6 months to determine if they need to continue treatment with a cholinesterase inhibitor. How we're going to do that is by talking to their caregivers. We're going to do a repeat MMSE or slums or whatever your facility uses. We can also ask about ADLs. Has that worsened over time? If they've had no change or a mild improvement at 6 months, then we're going to continue treatment. These are not medications that reverse dementia. These are medications that, maybe hold the patient in place or reduce the decline over time. If they do have a significant continued decline on therapy at that 6-month point, then you can consider discontinuation or changing medication. In general, 4 points per year is the average decline without treatment. So at that 6-month mark, if they've already gone down 2 or 3 points, then probably the cholinesterase inhibitor is not making much of a difference. So in this patient, would we want to change her treatment from donepezil to rivastigmine? No. So she's only gone down 4 points in 3 years. So that is pretty fantastic. I mean, that's worth celebrating. So we're probably going to leave her on donepezil and not stop it. Could we just leave her on donepezil and that's all? Absolutely, that's a reasonable option. Adding vitamin E is not going to be beneficial. There was a time where we hoped that vitamin E was going to be helpful, but the evidence has not borne that out at all. Adding memantine in this case is the best choice. Now, having said that, there was a 2012 study that did not show benefit with adding memantine to donepezil, as many of you know. There was a previous study back in, probably 7 to 10 years ago that did show a benefit, but again, it showed a statistically significant benefit and a questionable clinically significant benefit. So in general, using these two together, while many of you see this combination together all the time, and a lot of it is just for family support or for feeling like the family is doing everything they can to try and benefit the patient. So in this case, adding memantine is reasonable, but again, the actual evidence-based benefit you're going to get from it is still questionable. All right, patient case 8. So this is an 87-year-old woman who is in a dementia unit. So she has Alzheimer's disease, Parkinson's, osteoarthritis, and she requires total assist with bathing and dressing and help with feeding. So she's on donepezil 10, memantine 10 twice a day, carbidopa levodopa 4 times a day, oxybutynin extended release, and a multivitamin. Her MMSE score is low, it's 5 out of 30, and her GDS score is also low, 4 out of 15, meaning she's probably not depressed. She spends her time crying out, "Help me, help me." Which of the following additional assessment tools is most necessary in assessing this patient? So is it the BPRS, a functional assessment staging, an evaluation of incontinence, or the Framingham risk assessment? So let's look at these options. The BPRS is not something that we generally use in dementia. It is something used for psychological symptoms, but not specifically to dementia, so we wouldn't need that. The functional assessment staging is not important because she's already in a dementia unit, so you already know what her function is. It's pretty poor. Framingham risk assessment, hopefully none of you guys are worried about starting a statin in an 87-year-old woman who's already in the dementia unit with such a poor quality of life that she's yelling out, "Help me, help me," and her MMSE score is 5. So that leaves an evaluation of incontinence. And so why would we be evaluating her for incontinence? So the main reason is because she's on oxybutynin extended release 5 milligrams a day. So evaluating whether that is needed, which I would say even if, she was perfectly continent, would probably still not necessarily be needed because, again, it's going to be completely negating the benefit of her donepezil and memantine. Now, the other part to this question that when I look at it always comes up is what we're going to do with this patient. So again, are we going to change the carbidopa levodopa to continuous release formulation? That's probably not needed. Are we going to discontinue oxybutynin? I would definitely consider that one of the most important things we're going to do. Discontinue memantine or reduce the dose of donepezil. So I think C and D are reasonable options in the future, but probably the most important thing we're going to do right now is to discontinue the oxybutynin. In general, for geriatric questions, if there's an anticholinergic on the list, please discontinue it for the test, and there's a 96% chance you'll be right. All right, patient case number 10. This same patient, who with the MMSE of 5 and the GDS of 4, is medically assessed and reversible causes of her hypervocalization are ruled out. So which of the following represents the best approach to treating her behavioral symptoms? Are we going to implement a behavioral approach, add valproic acid, add quetiapine, or add citalopram? And as many of you know, one of the most difficult parts of dementia is treating the behavioral and psychological symptoms of dementia. This is especially hard on caregivers, and even in a patient who's in a dementia unit, there are definitely behaviors that do not respond very well to therapy. So the general approach to behaviors in dementia is to define the target agitated behavior. A lot of times someone will call and be like, oh, this patient's agitated. And you're like, okay, well, tell me what that means. Like, when are they agitated? What is the time that they're agitated? What do you mean by agitated? Are they hitting? Are they yelling? Are they doing something different? Are they actually reacting to hallucinations, which is different from the agitation? And really trying to consider contributing causes. So, I know that as pharmacists, you may look at this and be like, we're focusing on non-pharmacologic things in this, and one of the reasons for that is because in geriatric patients, especially in dementia, there are not great drugs, especially for treating behavioral symptoms. Because, first of all, the drugs don't work very well, and when they do work, then you're still having to deal with the increased mortality that we're going to talk about in just a minute. So trying to figure out what the actual contributing cause and doing something without drugs can be very helpful. There are patients who are considered resistant to care. And you say, what do you mean they're resistant to care? Well, they don't want to get in the shower. Well, that patient's a Holocaust survivor. So, as you are trying to put them in the shower in this new facility, they may be resistant to care because of the underlying history that this patient has. There are people who don't like to have male CNAs because they're very modest, and so they're resistant or they're agitated when they have to have a male CNA. So get them a female one, and that you can solve the problem pretty easily. So generally we're trying to consider contributing causes, do non-pharmacologic measures when we can, and then obviously there are going to be times when we need pharmacologic interventions. But some of the non-pharmacologic ones, trying to assess whether a patient has discomfort or pain. If you know that at certain time, it's only in the evening and it's only when they're being moved that they get agitated, it may be that they're having pain. So trying to manage that. Making sure they're not constipated and that they're actually having regular bowel movements. That can be very painful, and if the patient is far enough along in their disease that they can't tell you about it, that's a time when treating the underlying cause is going to be better than just throwing a med at it. Checking for UTIs. UTIs are very common in the elderly. Assessing other symptoms. Obviously, if they have a severe cough and other things, you may be looking for pneumonia or other infections. If the patient gets overwhelmed in an overstimulating environment, or if they're around a lot of people, a lot of times family members want to make sure they get included in things, and so they bring them to a party and then everyone's around them and they act kind of agitated, and that may not, while it may be important for the family members to feel like they're included, it may not be the right thing for the patient. One of the common things we see is paranoia. They forgot where they placed an object, so they're sure someone stole it. So offer to help them find it, rather than yelling at them for their paranoia. Having more than one of the same object can be helpful. Patients often will misinterpret things, and rather than taking it personally or trying to argue, this is very difficult sometimes, especially in a mother-daughter relationship I see sometimes, and trying to, for, let's say, daughters who are trying to help keep orienting their mom or their dad. So let's say that you have a patient and she is talking about how she's going to go see her parents, this afternoon. Okay, so she's an 86-year-old woman going to go see her parents. And her daughter is like, Mom, your parents are dead. Okay, so that's trying to orient her to what time and place it is. Hey, it's 2013, But now this mom has to grieve this. Because this is, for her, the first time she's hearing this, right? So this is a very, sad moment for her that could have been totally bypassed if the daughter said something like, hey, tell me about that time that you guys took that crazy road trip to South Dakota. Because short-term memory is what is first lost in dementia, but long-term memories, the stuff from when they were kids, all that kind of stuff, stays much, much longer. If you put on music that they listened to or danced to when they were teenagers, you'd be surprised. People who haven't talked for 2 years will bust out with all the words to that song. So that kind of stuff, those non-pharmacologic measures can be very helpful. Depression is often comorbidly seen with dementia, so if you see depression, do treat it. And patients with dementia sometimes see insomnia, and it may just be because they have less need for sleep. So putting a later bedtime in place, giving them more exercise during the day, again, non-pharmacologic ways you can kind of address some of these issues. So when do we have to go to drug therapy? So it's when the behavior is either dangerous, distressing, damaging to social relationships, and I mean like really damaging, and persistent, and they haven't responded to a bunch of non-pharmacologic measures, including the removal of the possible drugs, because if they're still on, anticholinergics that may be worsening things, then obviously we want to do that first. Or if it's an emergency situation and we're having to take the patient to a hospital or something else, then you may end up needing pharmacologic therapy. So if we have to treat, what are we going to treat with? There's a Cochrane review that suggests the best evidence is with risperidone and olanzapine, if it's specifically for psychosis and aggression. If we have to choose these, we want to start at low doses. If the patient has comorbid Parkinson's disease or they have a Lewy body dementia, then the risperidone and olanzapine are not great choices because of the EPS, and so something like quetiapine would be more preferred. And using for the shortest duration possible. I think this is another one where patients get started on something, often during a delirium phase, or maybe, when they're having something else going on, and then no one wants to take off the medicine because they're worried it's going to, make the patient terrible again. So I think at least trying tapers is really doing the right thing for the patient. Again, the adverse effects, as I'm sure you've heard in the news, and it's covered pretty exhaustively in your chapter, is the adverse effects include increased mortality. There's a recent cohort study back in 2012 that suggested the mortality was probably worse with haloperidol and maybe less with quetiapine, but that doesn't necessarily change how exactly we treat these patients. But obviously using antipsychotics is often necessary. But again, this is not something that we want to use. There's a lot of safety measures about trying to have a minimal number of patients with dementia on antipsychotics for these reasons. So for patient case number 10, implementing a behavioral approach is obviously going to be the first thing for a multitude of reasons that we already talked about. One is that hypervocalization does not respond well to drug therapy. Neither does wandering. Those two are very hard to manage with drug therapy. If the patient's aggressive or paranoid or has hallucinations, then there can be a role for drug therapy. Adding valproic acid, we used to do this more often, but there's really not great evidence for it. Adding quetiapine, again, would be a down-the-road choice, and adding citalopram if this patient had either a higher GDS or you had suspicions of it because maybe they couldn't answer the GDS very well, then you could use that, but behavioral approach is always going to be first. All right, so let's get out your cards again, and we're going to do patient case 11. So this is a 75-year-old woman who reports urinary urgency, frequency, and loss of urine when she can't make it to the bathroom in time. She wears a pad at night that she changes 2 or 3 times. Her past medical history is significant for Alzheimer's with a MMSE of 23, osteoarthritis, and hypothyroidism. Her UA is negative, and her PVR is normal. So which of the following interventions would be best? A, Bethanocol. B, pelvic floor muscle exercises plus estrogen vaginal cream. C, darafenicin, or D, oxybutynin. So please hold up your cards. A, B, C, or D. All right, great. So I see some B's and C's, so we'll talk kind of about the difference, and we'll talk about incontinence. So here is a lovely, free, non-copyrighted picture of the bladder. When we talk about urination, this is one of most people's least favorite topics, and to be honest, it was mine for a long time. And the pathophysiology of it is really kind of complicated to understand, so I'm going to try and make it as easy as possible to sort of think about. So storage is sympathetic. So storage, sympathetic, S and S. Peeing, parasympathetic. So peeing, parasympathetic. So think about those two when we're talking about sort of how things are managed and how we're going to do drug therapy. So this kind of goes through how the storage is what's basically responsible for, you need to be able to store things well. If you can't store it well and you have leaking, then that's stress incontinence. And we'll talk a little bit more about that in a second. And if you store things so well that you have urinary retention and things overflow, then you have overflow incontinence. So we're going to talk about stress incontinence and overflow incontinence sort of on this opposite spectrum. And then we're going to talk about the urge incontinence and how that is under parasympathetic control, that the actual urination part. So just to give you a slide with a little more information about some of the receptor sites that we're going to be hitting. So obviously there's sympathetic nerves involved in it. There's parasympathetic nerves, which are also involved in several different places. So we have cholinergic receptors. We have the beta-adrenergic receptors, which is a new potential target. We have alpha receptors. So again, this kind of gives you an idea about that there are multiple places where we're going to potentially have an impact. So the different types of urinary incontinence are listed here. So functional incontinence is basically where the patient is not able to make it to the bathroom in time. This can be because they're on opioids or benzos that make it really hard for them to kind of get started, or that they are less cognitively aware of their need to go, or they have really weak legs, so it takes them 5 times to get up out of the chair. You've seen patients like that. Urge incontinence is basically a bladder overactivity. So basically the bladder is telling the urethra all the time, like, it's time to pee, it's time to pee, it's time to pee. So urge is kind of with the bladder overactivity. Stress incontinence is a urethral underactivity. So we have that kind of storage part going on, but the urethra isn't able to hold everything in. So that's where we're going to see leakage if the patient is coughing or sneezing or jumping on a trampoline. Not that we see that many elderly people doing that, but that's, those types where you're putting kind of a pressure on the urethra. If there's leakage there, then that's considered stress incontinence. Overflow incontinence is due to the urethral overactivity and the bladder underactivity. So basically, the urethra is so overactive and so tight that nothing's coming out, and it backs up until finally there's a release of a whole lot of urine. And then mixed, which is generally urge and stress together. So we do have non-pharmacologic interventions for urinary incontinence, which is good because we'll talk about how the meds are also not ideal. Pelvic floor exercises or Kegels, which hopefully you've all heard about, which is basically a tightening of the muscles there to try and basically strengthen it. And this is helpful for stress incontinence, which would make sense, but it also can be helpful for urge incontinence. Bladder training is basically used to increase the time between voiding for patients who have urge incontinence. So if you've ever been anywhere and you're in the car and you really have to pee, and you come to the house and you put your hand on the door, and then you're like, you get all nervous because you're like, holy cow, it's like my body has held it this long, but now it's like, we're almost there, it's almost time. So there are lots of patients with urge incontinence where they get to the door and their body is like, everything is saying, go, it's time to pee, and that's when they lose their urine, when they're like, 20 feet from the bathroom finally. So those patients, they actually do training to try and basically kind of talk their urethra and their bladder down, and kind of they stop and they wait, and rather than running to the bathroom, they do bladder training to try and increase the time between having to go to the bathroom. Biofeedback can be helpful, and that's basically where you're using kind of sensors to make sure you're using the right muscles. Scheduled or timed voiding can be very helpful, especially in patients in a facility where, making sure that if they need assistance to go to the bathroom, that every 2 to 3 hours if somebody's taking them, that can definitely reduce incontinence. And then again, avoiding some of the contributing foods, or if the patient needs a pessary, making sure they get fit for that. So functional, as we already kind of talked about, the scheduled bathroom visits, using a bedside commode. If they have a tough time making it down the hall to the bathroom, giving them a bedside commode at night can totally reduce the functional incontinence. And then stop precipitating drugs that may be making them more impaired and slower to get up and get going. For urge incontinence, again, non-pharmacologic interventions can be helpful. The mainstay of therapy for urge incontinence, as I'm sure you know, is anticholinergics. Generally, there's equivalent efficacy, and we'll talk a little bit about the difference in some of the side effects and why that makes us choose certain ones in different situations. And we newly have a beta-3 agonist, and you kind of saw that the beta-3 receptor. So this is a different mechanism that could be helpful. So this is a slide of kind of comparison with some of the different anticholinergic adverse effects between the variety of anticholinergics that we can see for urge incontinence. So you can see the oxybutynin, we'll just focus on the dizziness category for a second. So oxybutynin crosses the blood-brain barrier very well. The IR the most, the ER probably the second most. Tolterodine is also at least on the list of drugs to avoid in the elderly because of the thought of crossing the blood-brain barrier. The topical oxybutyninins, the transdermal patch and the gel, they bypass the first pass metabolism, and so they actually tend not to have a lot of cognitive effects and tend to be definitely more preferred for patients who already have cognitive impairment when we do have to do combination therapy. The trospium, solifenacin, and darafenacin also have some evidence that they don't cross the blood-brain barrier, so again, those may be options for patients who already have dementia. The miragebron, the new beta-3 agonist, relaxes the smooth muscle during the storage phase, so your bladder is not trying to release urine all the time. There's no efficacy benefit over the anticholinergics, but there obviously is not anticholinergic effects, so that may provide its role for patients if they are not able to tolerate even the ones who have less anticholinergic effects. This could be a niche for that. It does have some dose-related activity on beta-1 receptors, so there are some cardiovascular side effects, and there's another one in clinical trials. So for stress incontinence, so again, this is for the urethral underactivity where it's not able to hold the urine in times of stress. Kegel exercises, pessaries, and surgery. Surgery is actually really effective, but again, you have to have a patient who is healthy enough to be able to undergo surgery. Consider stopping precipitating medications. So alpha blockers. So again, think about the effect of alpha blockers and alpha agonists on stress and overflow, because they're kind of on two ends of a spectrum. So alpha blockers can be very useful for overflow incontinence. That's what we do with our BPH. We use alpha blockers, but because they're tightening, because they're loosening everything up, it's going to worsen stress incontinence. On the other hand, alpha agonists like pseudoephedrine, there's some, patients who will, or some physicians who will still use that in stress incontinence because it helps to kind of tighten everything up. But obviously that's going to be way worse in using in overflow incontinence, and definitely worse than that. So ACE inhibitors don't cause stress incontinence, but if you have a patient who's got a dry cough all the time, then obviously they are more likely to have episodes of incontinence. Vaginal estrogens basically don't have superb benefit, but they do kind of reduce the incidence of urinary tract infections, and we see it clinically used a decent amount. Alpha agonists have sort of fallen out of favor, but you can kind of understand the mechanism. Duloxetine has some evidence for that, but the dosing is so crazy on it that the cost of it is prohibitive for most patients. Overflow incontinence, which again is usually caused by BPH or something like that, consider stopping the precipitating medications like alpha agonists, beta blockers, TCAs, anticholinergics, etc. If the patient has BPH, going ahead and treating that is going to address the overflow incontinence issue, and there can be a role potentially for cholinergic stimulation like bethanechol. So in this patient, bethanechol is not going to be the right option because this is a patient who reports urinary urgency and frequency. So that's definitely the two things you're looking for urge incontinence. Pelvic floor muscle exercises could be useful, but the estrogen vaginal cream would only be for patients with stress incontinence, which she doesn't have. So we're choosing between darafenacin and oxybutynin, and because she already has dementia, we definitely don't want to add oxybutynin to it. Even if she's not on donepezil, we still don't want to give an anticholinergic to a patient, especially one that's going to cross that easily. And so darafenacin could be an option for us. All right, patient case number 12. Please grab your cards. So this is an 85-year-old man who presents to his physician with lower urinary tract symptoms. A digital rectal exam confirms the diagnosis of BPH. He has a prostate volume of 31 grams, and his score on the AU-ASI is 15. His blood pressure is 118/70 sitting and 102/62 standing. So which of the following interventions would be best? Terazosin, finasteride, tamsulosin, or finasteride plus tamsulosin? All right, great. So let's talk about BPH a little bit. So we have alpha blockers as kind of the mainstay of therapy. So that generally includes all the older alpha blockers as well as some of the new ones which have a little less hypotension. They still all can cause hypotension, but definitely we see less with some of the newer ones. Alpha reductase inhibitors, including finasteride and dutasteride. The PDE5 inhibitors are new. In fact, I don't think it's on your slide, but the tadalafil or the Cialis once a day has been approved now for monotherapy for patients who maybe can't do some of the other classes. And then combination therapy. And combination therapy is indicated for patients who, when they have symptoms and then they also have a larger prostate size, because the finasteride or any of the alpha reductase inhibitors are going to be more helpful for patients who have a larger prostate and shrinking that up. Or if they have an elevated PSA, that's when the combination therapy with an alpha blocker and an alpha reductase inhibitor would be indicated. On page 56 in your book, there's a table that kind of goes through all the different options. On the top of page 54 is where the AU-ASI guidelines are in terms of how severe the symptoms are, the scores for when you would want to go ahead and either consider surgery or at least be thinking about drug therapy versus watchful waiting. So in this case, the answer that most of you chose was correct, C, tamsulosin. So terazosin for this patient who's already showing some orthostasis would not be ideal. Finasteride is not going to work for 6 months. So again, it's often an additive therapy, but we don't see it a lot by itself unless the patient can't tolerate it or they're trying mostly to treat prostate size issues. Tamsulosin is definitely reasonable in this patient, but this patient does not have a large prostate or an elevated PSA that would make you lean towards combination therapy. All right, patient case 13, so grab your cards. This is an 85-year-old man with pain from hip osteoarthritis. He also has hypertension, coronary artery disease, and BPH. For his osteoarthritis, he has been taking acetaminophen, 650 milligrams 3 times a day, and he reports that the acetaminophen helps, but he still experiences pain that limits his ability to walk. Which of the following interventions would be best? Do we want to change the analgesic to celecoxib? Do we want to add hydrocodone, change the analgesic to ibuprofen, or add glucosamine? So this is everyone's least favorite question, but throw up a card anyway. All right, great. So we have some answers all over the place. So osteoarthritis. So obviously the first thing that we're going to do in any sort of elderly patient is think about non-pharmacologic treatment. So again, things like ice and physical therapy and all those things can definitely be considered. Acetaminophen dosing. So this is a patient who's already on scheduled acetaminophen. Obviously you're aware of some of the controversies with the FDA reducing the dose of acetaminophen, so there's definitely kind of mixed feelings on whether we can still use 4 grams a day or we have to go to 3 grams per day. But obviously this is a patient where adding 1 extra Tylenol is not necessarily going to help him. NSAIDs versus opioids. This is probably the biggest controversial area. The AGS guidelines, which is the American Geriatric Society guidelines, would basically say that using NSAIDs in the elderly should really be kind of a last resort, not ideal. That not just if the patient has renal dysfunction, which obviously a lot of patients already do, and as I gave you the example, it doesn't take much to be with a creatinine clearance less than 40 anyway. But obviously even younger patients in their late 60s, early 70s who have been taking NSAIDs for a long time, it's obviously not ideal because of the GI risks, the renal risks, some of the drug interaction things. But having said that, so the AGS guidelines goes right out and says we want to use opioids, like that's, adding the hydrocodone or the oxycodone or something to treat osteoarthritis is the right way to go, which is how most geriatricians practice. But there's also some conflicting evidence from other studies that looked at the two and found that people on the opioids had more side effects than people on the NSAIDs. So for the purpose of the exam, I would say go with the guidelines and use the opioids, and in practice you're going to probably see both. But if you're going to use an NSAID, really trying to prevent the GI effects by choosing omeprazole when appropriate, which is going to be pretty much all the time. And then glucosamine is definitely something that we can use, but the evidence on it is very conflicting. It's not something that works right away. If you take it over time, is there some benefit for some patients? Absolutely. The anecdotal evidence and probably 49% of the literature evidence suggested it helpful, but then there's probably 51% which suggests it's not very helpful. So at least for the exam, the answer would probably be add hydrocodone because of the pain guidelines and because this patient already is 85 with hypertension and CAD, and the NSAID would not be a great option. All right, patient case 14. We have a 55-year-old woman with rheumatoid arthritis. She was diagnosed a year ago and began therapy with methotrexate. She's presently receiving 15 milligrams every week, folic acid, ibuprofen 800 milligrams 3 times a day, and omeprazole 20 milligrams a day. So today she's seen and reports a recurrence of her symptoms, and the x-ray shows progression of joint space narrowing and bone erosion. So which of the following interventions would be best? Do we want to administer a etanercept, switch to hydroxychloroquine, add prednisone bridge therapy, or change to leflunomide? So as we talk about rheumatoid arthritis, I think most of you are familiar that DMARDs are considered the first line of therapy. Kind of the big four that we see used first line are methotrexate, hydroxychloroquine, sulfasalazine, and leflunomide. In your book, on the table that goes on page 60 and 61 has a ton of information about some of the different options that can be used for rheumatoid arthritis. The biologic treatments are listed in that table as well, and there are a ton of them, and I don't even know how to pronounce probably 3 of them for sure. Again, these are therapies that are going to be more second and third line, but I would definitely refer you to that table really to look at a couple different things. So one is which ones can you use in combination with methotrexate, because there's definitely differences between the biologic agents about which ones you want to use in combination with methotrexate. Look at some of the infusion type reactions, which ones are sub-Q and which ones are IV, and kind of how to manage those. And then in the references section under rheumatoid arthritis, there's a reference number 4, which is the RA guidelines. And it's somewhat helpful because it tries to kind of steer you down a pathway, but a lot of the decision making around rheumatoid arthritis is very challenging, trying to figure out what's the right next step to add and what are the kind of the considerations that you take into account. So NSAIDs and corticosteroids, we see these used a lot in patients with rheumatoid arthritis. So just a reminder, this is usually we try to use these short term. This does not have an effect on disease progression. That's obviously the disease modifying. You definitely want to have your patient on a disease modifying agent and or biologic treatment in combination, where the NSAIDs and corticosteroids are very helpful for short term treatment. So we often see a patient maybe get started on methotrexate, but then they also will get a prescription for prednisone because obviously most of them are having acute pain and the methotrexate is not going to work immediately. So for this patient, we have some options. We could be switching to hydroxychloroquine or leflunomide, and some of you may say, well, those are both DMARDs, like why would we not switch to them? Well, hydroxychloroquine, if the patient has not done that well on methotrexate, we're probably not going to go seemingly backwards to the hydroxychloroquine. If the patient couldn't tolerate methotrexate, then we might consider hydroxychloroquine because it's usually a little easier tolerated. But if she's had a year and not really benefited, the hydroxychloroquine may not be as effective as the methotrexate. We could consider a change to leflunomide, but again, we don't have great evidence that it's any more effective than methotrexate, which is basically considered our first-line drug. There is some evidence that if you add on etanercept to the methotrexate, that there are patients who get a 60 to 75% benefit even if they've failed methotrexate. So that could be an option. Prednisone bridge therapy, you could still consider it, but it wouldn't be the long-term treatment for this patient. And she's already on ibuprofen, which is hopefully helping with the pain, but the x-ray is requiring something additional treatment to try and address the long-term progression of her rheumatoid arthritis. So with that, I am finished, and I have 2 minutes at least to answer questions here, and if not, I will answer them during the break. So any questions that you want to come to the microphone and ask? All right. Well, we will take a break, and I will let Brian tell me how long. 10 minutes, and then come on back, and we'll do GI. Thanks very much for your attention.